All right, the scary beast has arrived, the crash cart. Everyone always worries about this crash cart and it freaks them out, but we promise, guys, we're just trying to familiarize yourself with it. We're not expecting you guys to run codes by yourself at this point in your journey. You're not even an RN, you're not ACLS certified, we're not holding you to that accountability. First thing you always want to do with a crash cart is make sure you unplug it. When we're running these codes, we don't know whether we're going to be connected to power, it's in a patient's room, or it could be in the cafeteria. So we want to make sure that this defibrillator is able to function with the batteries that it's got. Everything on the crash cart, they try to make nurse proof, meaning we try to keep it as simple as possible. So a code is happening, the patient is not breathing anymore, has no pulse, one of the two. We want to make sure that we're alerting everyone. We're calling that code blue, guys. We want to send as many different resources to us to get us extra hands. We are going to be applying the quick combo pads. These are the defibrillator pads. In the old days, you've seen lots of TV shows. People had to do this, clear. We don't do that anymore. We try to be hands-free to prevent accidental discharge of electricity to people that shouldn't be receiving it. So we use these hands-free defibrillator pads. They've got pretty pictures on them that tell you exactly where they're supposed to go. So like this guy's going to go over here on the chest, this one over here on the side. In some ICUs, CCUs, or different facilities, you may see them placed anterior or posterior, but for our purposes, we're going to keep them just where the pictures show so that as not to confuse you. In real life, this guy is going to get plugged in to over here, but for simulation purposes, we're not going to have you guys do that. The reason why is this is a real defibrillator and we do not want you guys to accidentally discharge the electricity to yourselves. So for simulation purposes, all we want to see are these pads placed on the patient. In real life, the defibrillator does need the other regular 3 leads to be on as well, because the monitor in like a pacing mode is not able to sense the electricity as well as deliver electricity at the same time. So you'll also want the other 3 leads on. Moving down, we're going to assume we can just defibrillate this patient, so we're going to turn it on. We just follow the easy numbers 1, 2, and 3. So we've turned it on. Now we're going to need to select our energy. 100, 200, however much you want. Following number 2 comes number 3, so we're going to hit charge. While this is charging, we're making sure everyone's clear from everything? No. In the old days, we used to do. Now we've realized that took an extra 5 or 6 seconds to charge, and hey, that's a couple extra heartbeats that this patient could be getting extra oxygen in their brain. So instead, we wait till this is fully charged, and now we say, clear, clear, clear. We're making sure everyone's clear. No one's accidentally touching the side of the bed or anything like that. Who's in charge of making sure that everyone's clear? Everybody, but most importantly, whoever's pressing that button. Once you're ready, clear, 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 everyone's clear, we're pressing that shock button. Shock has been delivered, it's going to reset, resume whatever is on the algorithm for you to do. Those algorithms are already printed on the side. We don't expect you to memorize all ACLS guidelines, but you've likely already had your semester of cardiology, so you should know your rhythms and how to identify. We don't necessarily expect you to know how to treat. That's why we gave you the cheat sheet. So you would need to know the difference, like on this one, between like VFib, pulseless VTAC, and asystole versus PEA. You just need to know what rhythm it is and follow the algorithm. On one of them, you're giving epi first. On the other, you're giving a shock first. So you just need to know whether the rhythm is shockable or not by following the algorithm. How much energy do I use? Oh, it's written right there. What medication do I give? Oh, it's written right there. How much do I give? It's written right there. Just follow the algorithm, guys. Don't overthink it. The answers are right in front of you. Now we're needing to give medications, so we have our medication drawer. Medication drawer is full of mostly pre-filled syringes. So like epinephrine, for example, it'll tell you again once you open it. And some medications you may need to draw up and do a dose calculation on, but most of those calculations try to be pretty simple because they understand it's a high stress environment when this is going on, so they don't want people making crazy mistakes. We have our airway drawer, and this is more of an advanced airway. We want you to be familiar with it, but we're not expecting you guys to intubate patients or anything. This is the laryngoscope blade that the doctor will use to help intubate the patient. we have an ET tube. But if a doctor was just trying to intubate the patient looking down and doing this, we see this is really like floppy. We can't manipulate it the way we want. So they're provided with a stylet. The stylet goes down the ET tube before we hand it to the provider. And now look, the provider is able to manipulate it to get the right angle that they need to intubate the patient. Once this patient is intubated, the stylet will come out and the ambu bag will attach directly to here. There are different size blades for different size patients. Pediatrics, you'll have straight blades, you'll have curved blades. Again, just to familiarize yourself with the differences. We have our ambu bag. As well as oral airways that we would want to measure. You all know how to do the measurements already. I don't need to refresh that. So you would insert your oral airway and begin bagging the patient. Eventually, when there's a ET tube attached, you'll also add an end-tidal CO2 detector to the end of this tube. That'll just verify that you're in the right spot and not the doctor didn't intubate the esophagus accidentally. So, in a code, we don't want to be having to do that. That's going to take too long. So almost all hospital beds have this giant red, again, nurse proof, easy squeezy to find. Squeeze it, drops that head all the way back down. So now we can provide that high quality CPR. Oh no, this is a Tempur-Pedic mattress. It's not going to really provide that good backboard that we need. So most crash carts have a backboard on them. If not, right at the head of the bed, you can pull up and this can go underneath the patient as their backboard. That'll just provide that rigid back support, which will allow you to get those good compressions. This gets hooked up to oxygen. Ideally, if there's no oxygen around, some oxygen is better than no oxygen. So we're going to apply our mask over the patient using generally a C and an M so that this part of the mask gets tight. This part allows you to manipulate the jaw thrust to provide better airflow here as we're ventilating. We're making that tight seal, holding on and trying. As you can see, there's no chest rise and fall on this patient. That's because I really don't have a good seal. Most people, especially students, when you guys are first learning, take the time to have one person be in charge of that mask and doing CM on both sides, and have another person be the person that's squeezing the bag. You need to make sure that you're having that good seal, because if you're not having a good seal, every time you're squeezing, all that air is just leaking out. Actually, that's pretty much it for the crash carts, guys. That's all we're expecting you to be familiar with. The mannequin will show you in a different video the ability of us to monitor and track the rhythm, the rate, the quality of your CPR, and it'll be able to give you feedback in real time on your compressions. So during the code event, you might hear, we need you to pump harder, we need you to pump faster, good rate, good quality, etc. Just relax, take a deep breath. Oxygenate yourself first, then worry about oxygenating the patient.